That was a wonderful panel, and we're going to have something a little different next. And I look forward to moderating the next panel. It is an honor for me to moderate this panel. We've just heard examples of how 3 countries are implementing programs at the country level to improve quality of care at scale. In this panel, we will move up to the global level and see how it all comes together at the country level. We will hear about key priorities from the perspective of country, regional, and global stakeholders, and the catalytic role that development partners may play to strengthen quality of care in countries. I want to begin with a quote that I just heard, Hakuna Macheso. That's Swahili, right? My first Swahili, actually my second Swahili phrase. Hakuna Macheso, it means no more games. This is serious business. I had learned a couple of other Swahili words before. You all might have seen Lion King. Hakuna Matata. It means don't worry, be happy. So I think it's time now to actually worry a bit and really say this is serious business, and it's no time for games. So thank you for teaching me some Swahili words. So it is my pleasure to introduce the panelists. We have Dr. Blerta Maliki, who's from WHO, and she's the coordinator of the Quality of Care RMNCH network. Then we have Dr. Margaret Crook, Associate Professor at Harvard T.H. Chan School of Public Health and also Chair of the Lancet Commission on High Quality Health Systems in the SDG era. Dr. Soji Teti, Executive Director, Africa Region, Institute for Healthcare Improvement. And I welcome Dr. Jessica Sabiti back again on this panel. And you know, she's the Commissioner of Maternal and Child Health with the Ministry of Health in Uganda. So a little bit about this format. We're going to do this differently. There will be no presentations. It's going to be a moderated discussion. I will begin with a round of questions, and then that'll be followed by an interactive discussion among the panelists where they will ask questions of each other. And then we'll open it up for questions from the audience. Okay, let's begin the first round of questions that I will ask. Let me begin with a question for Dr. Margaret Crook. Dr. Crook, the Lancet Global Health Commission on High Quality Health Systems was launched earlier this month. In fact, it was launched 10 days ago. As the lead commissioner, you and the other commissioners had the opportunity to review extensive evidence and convene some of the brightest minds in health systems improvement. Can you provide us with a brief snapshot of the Commission's findings and recommendations, and what you see as the key implications for improving RMNCH health care at scale in low-resource settings? Thank you.
Thank you so much, Lily, for that rapidly answerable question. I'm glad I have a half hour. Really excited to be with you today for this discussion. As Lily mentioned, the Commission, which is a 2-year effort among 30 commissioners worldwide and a dedicated secretariat, really dug into this question of what do we mean by quality? What does it look like for people every day in low and middle income countries, and how can we change? And so we started really with this quite simple notion that health systems are a key determinant of population health, and that we know already that access to good health services can save lives on a mass scale. But that conversely, a lack of access to high quality health systems wastes lives. How many lives? Well, we estimated that 8.6 million lives every year are lost due to a lack of access to high quality care. So let's just think about that for a second. 8.6 million people die from conditions that are treatable by health systems today. We're not talking about extremely advanced care. These are SDG conditions that the globe has agreed should be within reach of all countries in the next several decades. Of the 8.6 million lives lost, 5 million today are lost among people who have already reached out to the health system. They've sought care, they're in care, and yet they are dying unnecessarily. And these are deaths due to poor quality, which is the reason we're all here today. So the Commission, when we saw these numbers, really took a step back to redefine what we mean by high quality health systems. If they're truly to be a determinant of health, what does it take? And we started with the notion that health systems are first and foremost for people. They're about people, they're for people, they need to be completely focused on the well-being, the trust, and the confidence of people. And we see health systems, high-quality health systems, as having three key functions. They need to produce and protect health. They need to generate trust and confidence in the population. And they need to be able to change and adapt when health needs change and people's preferences change and technology changes. They've got to change. They are not static entities. And so you can see from this definition that health systems to us are not just a health-producing institution, but also a social institution with responsibilities for better health, but also confidence. And also, the Commission concluded that we need to really raise our standards. In fact, our collective ambition has for too long been too low, and that we should be judging health systems on their performance, particularly in the areas of care competence and people's experience, and also on the impact of systems on lives saved, on suffering reduced, on trust, and economic benefits for families. We all know, I'm a doctor first, that stethoscopes, that antibiotics, that vaccines matter, but they don't themselves equate to good quality. We have to stop measuring inputs and calling that quality. And we found in our investigation pretty broad and deep gaps in competence and outcomes. Those things that I just mentioned really matter. Let me just give you a few examples relevant to maternal newborn child health. For example, we found that fewer than half of mothers receive a visit from a trained provider within an hour of giving birth in a health facility. What's the point of going to a health facility if your provider doesn't check on you to diagnose that postpartum hemorrhage, which develops postpartum and must be diagnosed and identified early for treatment to succeed? In fact, the figure half was a recurring theme in our investigation and our analysis. Half of needed clinical actions are done in a typical antenatal care visit. This is a routine type of care that we've known about for 50 years. Half of parents leave a sick child visit knowing the diagnosis. And overall, about half of maternal deaths are directly attributable to lack of access to high quality care. So, when we look at this in totality, it's like health systems are flying with only one engine. It's difficult to believe they're going to get us there. They're going to get us to the SDGs. They're going to get us to the grand promises of universal health coverage if we don't take quality seriously. And so where do we go from here? We spent quite a lot of time looking at solutions, looking at approaches, ways of thinking. And because health systems are complex adaptive systems, they're not linear machines where simple inputs translate directly into desired outputs, the solutions do not lie on the surface. That is where the problems are apparent, but the solutions lie elsewhere. And indeed, we felt as a commission that we needed to overhaul our approach to improvement. And that meant moving from individual providers and a clinic at a time or small pilots of clinics to consider the roots of health systems and actually look outside of the health system to think about how to transform the experience and the outcomes of people. I'm sure you've heard the phrase that every system is perfectly designed to get the results it gets. And so if we want different results, we need different systems. So the commission really looked, by the way, extensively at the literature on quality improvement strategies and on complex adaptive systems and what does it take to change. And we identified 4 universal actions that we think are pertinent in most settings, and we think that every country should have a look at these. They will look different in every setting, but the themes we think are very relevant universally. So the first of these is governing for quality. The essence of health system governance should be quality. It's sort of the basic proposition of the system. We're not there to cut hair or to sell shoes. We're there to make people better. And the only way to do that is to have our clients get the quality that they deserve. And so you need a unified focus strategy for sure. And I'm delighted that Blerta's here, and WHO has been a wonderful partner in the Commission and in working on a national quality strategy that's so critical. But we don't just need paper. We need leaders who are willing to carry the torch for this. And I was so happy to hear in Uganda that the Prime Minister, even at that level, has acknowledged the key responsibility of the health system to provide that standard of good care. And that's actually the ideal situation. That's where we want it. We don't want a quality directorate over on the side and some small, poorly lit room running quality for the health system. It's got to start right at the top. And it also requires a humility and a desire to learn, a willingness to acknowledge errors are made, that not every worker is actually fabulous. Some workers need to be assigned to different tasks. Other workers need to be uplifted and supported. But that systems need accountability, and someone should be accountable for it at the end, and we need that person to be a high-level person. Service, the second universal action is service redesign. So systems have historically been organized to maximize people's access to care, which comes for very good reason. Originally, systems were not accessible to rural populations, and so many countries started building clinics, and they've done a great job. When we map clinics, as the Commission did in many countries, we see that countries like Uganda, Tanzania, others have done a great job in bringing clinics very close to the door of people. Not perfect, and there's still underserved areas, Zambia, other places with remote areas. But we've done a decent job, and actually politicians have come to love this. This is a reliable vote getter, cutting ribbons on clinics. And I think the question we need to be asking is, it's time to shift from maximizing access to maximizing outcomes. And that means that these clinics that are there, assets on the ground, as I heard someone refer to earlier, may need different functions to be able to maximize the health of their populations. So for example, why are deliveries being done in small facilities without any real or realistic recourse to advanced care should the mom run into problems? We all know that a woman who's bleeding or seizing in a remote rural clinic, even with a dedicated midwife, which is not always guaranteed will be there, cannot really get to that C-section or that advanced intervention for herself or her newborn in any time to save her life. It's just not happening. So we need to be moving deliveries to the place that can get them done properly and respectfully for the woman without incurring an epidemic of C-sections. I think there are lots of examples to learn from that incorporate, for example, midwives and obstetricians working side by side with generalists, with care teams. Lots of ways to do that, but let's make survival and respect first and foremost in our considerations, not proximity. And this is why we need better roads and better transport and the private sector to all join hands and work on this together. It's not just the health system alone.
Margaret, we're running short on time.
Sure.
Thanks.
So the third universal action is transforming the workforce. We don't think that in-service training is really cutting it. We do need to update and urgently the training curricula for doctors and nurses, as well as their clinic environment and their leadership and management and pay. And the fourth opportunity for improvement, fourth universal action, is to enlist the people themselves to demand more quality. One of the biggest surprises for us in the Commission was the high marks that people give to objectively poor quality care. And we think this stems from lack of empowerment, but also lack of information of what good quality care looks like, and frankly, lack of exposure to it in many settings. So we think this is another really underappreciated opportunity to put pressure on systems in constructive ways to improve performance all around. Thanks.
Thank you. Thank you. You thought 7 minutes was too short. They've actually been given only 4 minutes each. So a lifetime of work, boiling it down to 4 minutes is no easy task. Thank you. Moving on to my next question is for Dr. Jessica Sabiti. Dr. Sabiti, Margaret Crook has outlined 4 universal actions recommended by the Commission, including the recommendation that health system leaders need to govern for quality by adopting a shared vision of quality care, a clear quality strategy, strong regulation, and continuous learning. As a Ministry of Health official who has supported countrywide RMNCH quality efforts for many years in Uganda, can you please reflect on what this recommendation means to you and share learning from the Uganda context? Thank you.
Thank you very much. I'd like to begin by highlighting a risk, I think, which countries are facing in the push for universal healthcare coverage. I think many countries are still struggling, of course, coming from the MDGs, on translating what universal healthcare coverage is. I sit in several meetings and I look at the leaders struggling with a diagram, with that, and I think it's very important at this point for us to go back and make sure that quality is centered very well, and translate this in a very simple way. Having said that, I think for leaders to govern quality of care, I think it's very important that we change our approach. In addition to centering quality of care and making sure that quality of care is not only a service, but it's a right, it's an equity issue, it's an accountability issue, that we bring everybody on the table. We need to engage in a meaningful way. For example, when we talk about adolescent health, most people look at people, vulnerable populations, as people who need, as beneficiaries. When are we going to bring these people as experts on the table? And I think that's the biggest challenge in countries. Partners and donors don't want to fund these processes because they don't bring quick results. And even countries don't also monitor these processes. They don't even invest money in looking at these perspectives. So I think the issue of meaningful engagement, having bottom-up approach, having citizens' voices and getting their perspective on the table is going to be a new thing for countries to do. And the other thing is also to make sure that we are using data. Many countries have difficulty using data or getting very good data. And even when they get good data, sometimes they may not use the data for many other reasons. So investing more money in data, having a data reform process going on in countries, especially routine data, for me, I think it's going to be a very important thing. Instead of waiting for data for 5 years. DHI, as I said earlier on, is very good, but we need to have other processes which can capture and make our work responsive to what people are saying and what they are feeling. We need also to think carefully about local adaptation. In Uganda is well known for adopting interventions. If you have a new initiative and you want to try it, go for Uganda. I think countries need to go back and think through how we adapt and invest more money to understand how interventions are brought to countries, how they flow into the countries, who brings them, who was there, who prepared for them, and who consented. So I think the whole issue of adaptation is very important. And WHO in the old days used to invest in adaptation. But if you look at increasingly most of their initiative, there's no time for adaptation. Right now, WHO has released the Code of Care Standards. They have 136 or something measures. And we're struggling. They're all important. Some people say, oh, everything is important. So when you try to challenge and say, let's do some few things, some people will disregard that. So we need support. We need to nurture these processes, and we need to work with our leaders. We need to build capacity in the local leaders, and we need to believe in bottom-up approaches in country and also working with partners. Engage in a meaningful manner. Let the community become an expert. Let everybody become an expert. And let's work within our resources. Thank you very much.
Thank you. Thank you, Dr. Sabiti. My next question would be for Dr. Soji. Dr. Soji, you have significant boots on the ground experience improving healthcare, wearing different hats. As a clinician, as a member of a hospital management team, as a quality improvement coach and practitioner, as a leader of a QI initiative at national scale in Ghana, and now as IHI's Executive Director for Africa. Based on your real-world experience and your current role supporting healthcare improvement across the African continent, what does it take to improve healthcare at scale, and how can partners best support governments in this journey?
Thank you very much, Lily. I'd just like to start by saying that this is really an auspicious year for quality. When some of us started doing this work over 10 years ago, I don't think that we had this kind of global momentum. So the 3 reports that have been issued this year, I think, provide an important focus point for the conversations that we are currently having. I'd just like to start talking about the quality strategy, which is called out very clearly in the Lancet Commission report. And I think the experience is that there's wide variability in the kinds of quality strategies that the various countries are working with. There are those that do not have that overarching strategy, and there are those whose strategies are very high level, very aspirational. And I think the need really is to be able to have detailed implementation plans that show very clearly how those national aspirations can be cascaded down to the regional and then to the facility levels. So that is key. And I'm saying this because IHI is just coming to the end of 5 country case studies that we've just done. Nigeria, Ghana, Scotland, Mexico, and Ethiopia. These are countries that we've supported at the level of the ministry to develop and are now implementing quality strategies. The second thing is that it is important, as the Lancet Commission points out, that we need strong regulation, we need learning, we need good accreditation systems. But I think what needs to be emphasized is that it is not so much the existence of these initiatives, which are often cast as separate, disconnected, initiatives that the countries will pursue. What is more important is how we coordinate these separate activities to be able to achieve those population health outcomes, which is why these days we are talking about a quality management system. In other words, what are the governance structures at the national and subnational levels that can be able to tie the gaps together, help to prioritize, help to commission teams at various levels of the health system, and help them to be able to drive those improved health outcomes. Because without that systematic governance, we really would not be able to get the outcomes that we are looking for. Leadership is key, but leadership is not just at the national level. It's in the hospitals, it's in the communities, and all of these people need to be brought on board. So currently what we are advocating for is that when we even talk about quality management teams, community members need to be active members of those teams. And I know sometimes that makes health professionals a little bit uncomfortable, that they would get to know trade secrets or whatever, I don't know. But really that is where we should be heading for. And that really links up to the 4th recommendation about stimulating population demand. So the conversation is, can we create mobile applications where when people visit facilities, similar to what happens in the hospitality industries, people can give direct feedback. There are conversations in places like Ghana where we are talking about creating league tables to show who is performing well in areas of trust, confidence in the health facilities. They are talking about community scorecards where we would have focus groups in various communities so that there'll be direct feedback to the facilities, not in a judgmental way, but as a sort of cooperative mechanism. You raise the issue also of partnerships and how we can work as funders and as partners in these communities. What I would say is that there's a need for some humility on the part of funders and partners, because a lot of the time you would have partners and funders coming into these countries very high and mighty. They've scoped the country, they know what the problem is, they have prepackaged interventions, and they want people to adopt these things wholesale without realizing that you cannot wait till 6 months to the end of your project before you start asking who is going to sustain these interventions. These conversations ought to have started at the beginning when we were designing the interventions. So co-design, co-implementation, very, very key, tenets that we would need to take on board. I had the singular misfortune of working with a funder in a country where funding was almost cut because the accusation was that we as IHI were paying too much attention to the ministry. So the question is, as funders and as partners, the question needs to be asked. Do you want a pilot project with breakthrough results, publish your publication in your journal, and then you go away? Or do you really want a sustainable intervention that is owned by the country and that is integrated into their systems? And I think this question ought to be answered very early. There's also the issue of harvesting best practices. Really, Dr. Ongwe talked about learning on a small scale, documenting what is working, and then rapidly scaling up. These countries are not coming from pure deficits. I mean, there are assets in these countries, things are working in multiple places, but in many places we are struggling with ability to really harness what is working in a systematic way to inform what is happening at national scale. And I think there's a lot of opportunity to do this. We have half-year review meetings, monthly review meetings that are happening, hospital meetings are happening. So we would just need to be more deliberate about harvesting these best practices and promoting them at national scale. And where best practices are concerned, I think of them mainly in two ways. There's the content, and then there's the process. In terms of the content, I see that there's a lot of attention to what did you do differently to be able to get the results. So what is the innovation? And that is the content. But I see that there isn't much attention to the process. What changed in the workings of the health system to make this outcome possible? So sometimes people want to take the innovation, but they do not want to change the way the health system works. If it took us monthly site visits, coaching and mentoring supporting visits to be able to get the results, what makes you think that in the routine system, visiting them half yearly would get you those results? And how can we change the workings of the health system to be able to support this new way of work? I think these are some of the critical questions that need to be addressed if we want to get the outcomes we are looking for.
Thank you so much. Rapidly moving along to the last question, to Dr. Blerta Maliki, WHO. Blerta, over the last couple of years, the WHO established a quality of care framework for RMNCH and has launched a country-centered quality of care network for RMNCH in 9 countries. Can you briefly tell our audience about the network and why WHO established it, what was the rationale behind it, what is being learned through it, and what are the challenges and opportunities and future priorities of the network? Thank you.
Thank you very much, Lily, and thank you for the invitation to be part of this panel. It's very important, not for WHO, but for the momentum we are living around quality of care, to be able to talk about how we work together, why we're working together to address quality, and what is the biggest challenge in this quality world that we are so excited about it. Before I go into any details about the network, I would like to thank, I think, most of the organizations in this room. And the reason for thanking them is that USAID, with a number of organizations, with a myriad of organizations, in the past 20 plus years, at least in my professional history, has invested heavily in looking at what quality means and how to improve quality of care for health systems at large and maternal newborn child health specifically. So I cannot not mention MCSP for the last 4 or 5 years that has been a champion, a challenger, and a positive supporter of this agenda. SNL and Save the Children, who are continuing the same legacy in terms of quality of care. MSH, that is now like one of the major supporters of quality historically, not only today. Or other organizations, URC Assist, and I'm sure JPIGO, I'm sure I'll forget all of them. But I think this is important to recognize that a lot has been happening in the past. A lot has been learned about what quality is and how to go about quality. And the challenges that were placed to WHO, I would say well before commissions or reports. This is towards the end of MDGs, when we were clear that coverage was improving, availability and accessibility of services was enhancing, but the results, morbidity, mortality, and equity wasn't changing with the same pace. So what does it mean? Why for maternal and newborn health is so challenging to get into the results we want? And it was at that moment when the challenge was posed to WHO, end of 2013-14, saying, what you as an organization are doing to help countries to shift from this thinking of only get to everybody with what it is needed in the moment it is needed in the appropriate way. That was translated into standards, which helped us as an organization and the entire global public health community to articulate moving from guidelines into the without implementation. And that is where the beauty of the moment comes, because having standards doesn't mean that standards will be implemented by themselves. How do you move into an implementation of such an ideal world, for many people still aspirational world, was the question that was thrown at us. And the question wasn't just, not only that, it was, how do you do this in a way that is sustainable at scale? How do you implement quality of care everywhere in the same way? So that was a question that was behind the establishment of the network, which happened, I would say, as a momentum in February 2017. But as a process, it started well before that moment. We did have, we are privileged to work with this myriad of partners, and we are privileged to work with countries that have already a good experience in a good or bad or good experience in terms of trying to address quality of care. So Dr. Jessica is one of the representatives of the 9 countries in the network, Uganda and Nigeria. We already heard 2 experiences that come from these 2 ends in terms of what it meant for them to start engaging and to pack what already was happening in their situations and context in a way that was looking at what does it mean to build institutions, what does it mean to build systems that support quality, not anymore as a project or as a one point on time, but as something, as a function that the system has to deliver all the time routinely. And I think this is one of the biggest shifts that we're looking, and is a challenge for us all together, because people look at quality as a goal, aspirational goal or objective. And we do not think about this has to be delivered and has to be delivered throughout. So the network was established as such in 2017. 9 initial countries, 2 are already in the room, and 7 other countries, mainly in sub-Saharan Africa. India and Bangladesh are outside that region. And now we are looking at Kenya and Sierra Leone as 2 additional newcomers into the network. Collectively, we sat down and we said, what does it mean for us to do this work in a way that is sustainable and at scale? That translated into the strategic objectives of the network. I'd really invite you to look at those 4 strategic objectives. In a nutshell, is leadership, action, learning, and accountability. And this is well before the Commission recommendations came in, into which the leadership is about governing, institutionalizing quality of care throughout the health system and supporting it. Action is about bringing more than only quality improvement or packages, already packaged interventions into the world of RMNCH or even broader. Learning is the piece that brings together data and information with the how-to, what is that best practice and that innovation that is worth, and how do you go for that innovation at scale without forgetting the processes and not just singling out one innovation, but the entire way how you do it. And accountability, which moves mainly towards not only demonstrate and be accountable, but create those elements and forums in which you can demonstrate that accountability, in which quality is articulated together with women, children, and the communities where they belong, so you are accountable towards what your community needs. The implementation of this type of approach is now ongoing in these 9 countries. I think I would be more specific in saying what they've done, because it has been very, Dr. Jessica, she already hinted into the different ways on how this is happening in the countries. But the most important was that recognition that we're not starting from scratch, recognition that nobody knows the exact answer to this question, and that we need to sit together and co-produce. So bringing together all the stakeholders and partners under the leadership of a government, full, thorough ownership and leadership from the national government, and the same type of leadership and ownership being translated into the subnational down to the facility level. So looking at who's doing what, identifying gaps, looking at the different packages of implementation around quality of care, bringing the experience of a system, and looking very clearly that countries having established or aiming to establish their national strategies on quality that is beyond a paper, structures that look at the quality, and then how that links with the programs. Countries are now at the implementation stage, and there are many challenges that are coming with implementation, including already we had some preconceived answers in the network and among all of us saying we know how to go about it. And now we're finding out that we know how to go about it in different ways, in different manners. So how can we synthesize or bring this together in a way that makes sense for different contexts and gives the country the opportunity to contextualize, not to go with one model that fits all. The second biggest challenge we have is measurement. And I don't want to go into all the comments around measurement, but it's important to identify that the measurements of quality are important at all levels. Not everything is important in each level. So where quality is improved at the point of delivery, when the woman or the child meets the provider, that is where you will need a myriad of measurements that will tell you how your practice is changing, what is happening, and then you can improve one by one, bit by bit as you go. At the district level, you need a change in thinking around quality and those tracers that will tell you how it moves. And then at the national level, you need to be more strategic. A lot of work MCSP is doing and is co-leading around the monitoring and evaluation working group of the network, together with other organizations in the network, especially on the learning and the implementation. I think I'll stop here because there is no more time. I did have 2 more things to say.
Oh, I didn't even know there was a
Thank you.
clock there. In fact, I've just been informed we've run out of time, and we did have a plan to have an interactive session where the panelists would ask each other questions, but I don't think we have time for that. But I have been allowed one sort of a redesigned format for this. I will end with one question. We will have a little bit of time for the open Q&A from the audience. But before we do that, let me just ask one question, a burning question that I had, and I would ask anyone from the panelists. I would also invite Dr. Onwe from Nigeria to also respond if you like. This question is about really sustainability. I want to remind you what Barbara had said in the opening remarks about the buzzword at USAID is journey to self-reliance. And another way of saying that is sustainability, which we have been saying it all along. So, we have all, as international development partners, gone to countries, provided technical assistance, and we know of cases where things fall apart when we leave. And there are many reasons for that. So I would like to focus on that one question instead of having this interactive discussion among the panelists. And anyone who'd like to respond, I would really like to hear from the countries especially. And Dr. Soji, you have a lot of country experience, even though you're working as a development partner. So if you could sort of reflect on the sustainability of all this work that we're doing, is it really sustainable? Do we have to work in a different way if it's not sustainable? And what would that different way look like? So let me stop there with that question, and anyone can respond. Thank you. Dr. Onwe, please also.
Thank you very much, Lily. Sitting down and listening to these panelists, I have moved back to Nigeria and come back. And the simple reason is that quality of care is not new, yes, but systematic implementation of quality of care, the way we are going about it, is new to many countries, especially Nigeria. I see it as MCSP is midwifing the process. I have just given birth to a new baby. And I think that it will take time for the system to internalize it, integrate it into our system, and then make it sustainable. And it involves a lot of things. One, Nigeria is just developing her second National Strategic Health Development Plan. And it's good. I think for Ebonyi State, there are a lot of things bordering on quality of care that has been integrated into that plan. Fine. But that is just the first phase. And most of the time, it's good to have the strategic plan. It's good to have everything. In the last 3 years, we reviewed the previous strategic development plan. The level of implementation for Ebonyi State was just 29% implementation level. So even when some of these have been captured in the country's strategic plan, it still takes time for implementation to actually be achieved. So the core message I'm sending is that quality of care is not as old as we think in our settings. And we need to really think of how to make it work, because we need more time for people to understand what it means, especially at the higher level. Those are the people that will strategically take the decision. At the state level, if no matter how good the commissioner, the permanent secretary understands it, no matter how beautiful the document is, if the governor does not buy into it, you won't have fund. You will not have fund. And getting these messages across all the levels will take time. And particularly in Nigeria, I'm worried because MCSP closeout is coming during a political transition period. So, and we don't even know, assuming Lily stands up now to say, let me go and talk to that person. The person will listen. He may convince my governor today, and by February, there is a new governor sworn in, and we start afresh. So there are so many issues. So, but the bottom line is, yes, we are going there, but it's a long journey, and we have just started. Thank you very much.
Thank you. It's a long journey, that journey to self-reliance, and that road is full of potholes. Should we have one more response from here, and then we'll open it up for general Q&A?
Okay, well, I would share something. I think that sometimes we don't pay sufficient attention to the internal decision-making processes of the respective countries. And if we do, and the decisions around the agenda setting and how we prioritize are embedded within those decision-making processes, they stop becoming the decisions of partners, but the country's own decision. And I'll give you an example, where in Ghana, when we started this whole conversation around developing a quality strategy, we could have gone in as the Institute for Healthcare Improvement and had the conversation and put it out in that manner. But we made sure that the conversations ended up in the need for a quality strategy being captured in the medium-term strategy and being escalated to the health summit. So at the end of the day, in a communique that was issued by the ministry itself said that it needed to develop a quality strategy. That meant that it had been taken out of our hands. And immediately it got into that communique, it meant that it had to be reported on annually to the stakeholders in the country. So it was embedded in the technocratic system, and it meant that it would go irrespective of who was driving it. The second issue has to do with funding. I think quality and all the things we're talking about sometimes require funds. The reason why sometimes coaching and mentoring supporting visits cannot happen at the same frequency is because there's no funding to buy fuel and take them to the sites. So a careful conversation needs to be had for us to come to the realization that it costs money as well. And for the governments to be able to budget, even if it's a small budget. So now that's really what we are doing. At the beginning of the conversation, can you also put something on the table as a government, as a country? Even if it's a venue that you are going to provide free of charge, it's a contribution. And then as we get to the end of the project, it becomes clear that the country's own funding also increases. The last is capacity building, not assuming that people know how to do all of these things, but to be systematic in the way we build capacity. But even as we build capacity, to de-jargonize, not push lean and Six Sigma and model for improvement, but to understand that the core concepts are basically the same, and to focus on those core concepts as opposed to pushing some particular methods down the throats of the poor ministries.
Thank you so much.
Yeah.
So I'm really sorry to say that, I would have loved to hear from the other panelists as well. There's so much wisdom and expertise here. But we have really run out of time, but we do want to give the audience maybe 2 or 3 questions. How many are we allowed? Sorry? 3. Okay, 3. And maybe we'll take one of those questions from the overflow room. So 2 from here. Anyone wants to go first? None? Maybe we can have that interactive session. So here's a question for Dr. Sabiti from the overflow room. Is this for now? Okay. So let me start with this while you're thinking about a question for any of the panelists. So Dr. Sabiti, here's a question for you that came from the overflow room. It says, the quality strategy in Uganda is impressive. However, is the data presented and the programs discussed only at the Ministry of Health facilities and public facilities, or does this program and initiative also include the many private not-for-profit facilities in Uganda? Private sector question, very good.
Yeah, thank you very much. I think that's a very good question because that is one of the areas we've been struggling. The data we have been collecting in the 5 districts, for example, using the WHO standards, includes both public and private facilities. In some districts, we have so many private facilities, and the discussion which is going on now, whether we should sample a few of them. The biggest problem we have had is a historical problem where the private facilities do not contribute to the health information system. And starting from about 3 years ago, there's been a process of trying to make sure that the private facilities also contribute data. But there is no incentive, there's no, even the utilization of the data is not very effective, so we still have a long journey to go. So it's true, not all the private facilities are included. We have started slowly, but we still have a big way to go. In terms of percentage, I would say less than 50% or even much lower. Yeah, not yet.
Thank you. Is there any question from the audience? Yeah, I see one hand up. I see 2. Okay, we'll take those 2.
Hi, my name is Grace McLean. I'm a Health Research and Evaluation Officer at International Rescue Committee. And I'm curious if anyone has any experience or insights into applying these quality improvement initiatives in a humanitarian or emergency context. So trying to make sure that the alignment of the stars isn't totally derailed in a disaster or conflict situation. Thank you.
Thank you. Great question. Troy, you get the last question.
I was hesitating. I'm Troy Jacobs, USAID. And when we were talking about, Paul Batalden had a recent commentary about co-production. And we were talking about sort of co-production at one level, but there is a flow of knowledge, learning, and what I don't see is we've got expertise in low and middle income countries, and we are sitting today in a place like Washington, D.C., where we have quality of care issues. Some of the indicators are just as bad as in Africa. And to change the relationship, the flow of information, the expertise, so that in fact, we have experts in these countries that are informing high-income countries in the same way as co-equals. What do we need to do to change that type of co-production?
Great. Thank you. Wow. So who would like to take the question about the humanitarian context? And for the co-production, I was wondering whether, Margaret, you'd like to respond to that? Or
Sure.
Okay, great. So humanitarian context, anyone feels comfortable responding to that question?
Yeah, I can try to answer that question, but just to warn you that in Uganda we have adopted a very unique humanitarian model, especially for the refugee setups, is that our refugees actually are incorporated in the host communities. So it's slightly different, but in some districts you find that actually they're still in the refugee setup, some of them, but we have adopted a model which is inclusive, and that means it has both effects on the refugees themselves and the host communities. But we are working with UNICEF in those districts to develop systems and set this cult of care in place. Interestingly, the same standards and the same processes actually apply, because they're the same values and standards, and that's what we are trying to foster. The only problem is that we are also trying to make sure that the host communities are not marginalized. We've seen situations where you have piped water passing through the host communities and going to the refugee camp, and the host community doesn't have enough food. We've seen refugee communities come and settle in a place and they clear the whole forest on their given land, and the local people don't have the land. So again, the same model is applicable, but I think it's also opening up our eyes that actually when you have such situation, doesn't mean that actually the humanitarian crisis people are worse off always than those who are better off than the host communities. So it's also helping us to balance, and we're using the same model.
Thank you.
Can I only say that
Yeah.
it is one of the areas of work that we would like to work on it. We have started a little bit, so if anyone is interested, please see me after this end.
Great.
session.
Yeah. All right, Margaret, do you want to take the last question?
Sure, thank you for that question. And let me both endorse and also dissent from parts of your comment. So where I would dissent is in, I think, a false equivalence between the problems we have here in the US and in high-income countries, and frankly, the problems that I have witnessed, but really colleagues around this table live with daily in rural and urban settings in the lowest income countries. I think it's become quite popular to say we all have struggles, and that's true. We have huge inequities in this country that are absolutely insupportable and immoral, I would say. But they are not equivalent to the challenges that women and men face daily in Uganda, in Tanzania, countries that some of us are very familiar with, others much more so. So I think it is not helpful to paint them all with the same brush. In terms of the health system experts, I couldn't agree more. I think it should be our joint ambition to support and create and build the type of health system science workforce, frankly, that can do the hard analyses, that can inform, that can provide the data, that can support the Ministry of Health, which frankly every day doesn't have the time nor the resources to be digging in and understanding trends and confidence intervals and you name it. And I think those folks exist already. There are wonderful universities and countries. Other people exist, maybe already exist, focused on perhaps slightly different areas, whom we could redirect and engage in this struggle, in this revolution on quality. And then others still need to be supported and developed and mentored over time. And one thing I do know is it is not fixed with a week-long STATA training course. It is not fixed with conference calls where we drop off every few minutes. But it is fixed with a sustained and respectful engagement over long periods of time that goes to master's level training, bachelor level training, and doctoral level training to build up the kind of health systems research and data workforce that countries need.
Thank you so much. We have really come to the end of our session. We don't have any more time. I would really like to thank this wonderful panel of experts. I want to echo what I heard Margaret say, that it will take nothing short of a revolution to achieve the bold goals of the SDGs, and Hakuna Macheso. Thank you all.
Thank you, Margaret.
Oh, and Koki will close the panel, and she is, I think she needs no introduction. She's the director of MCSP.
I know we are out of time, so I thought actually I would tweet my reply, but I don't know if that'll go down well with this audience. So I just wanted to take a minute to thank all the speakers, the moderators, for this enriching and engaging discussion and thought-provoking dialogue we've had today. And to the Woodrow Wilson Center for being such an immense and tremendous partner with us, and being such a great host with us. A big thanks to our MCSP communications team. I know that was not in my closing remarks, but I have to thank them for everything that they do to make these sessions successful. The sharing and the learning that we've seen and heard this morning reflects both the complexity and the possibility of really driving quality agenda forward at scale. So it's exciting news, but it's important that we implement a systems approach that brings together multiple stakeholders at different levels. Makes me so happy to see some of the results from the countries that's showing tremendous progress over time, some of the countries that we visited and worked in. Through these two panels, I think it's very, very clear that we need to have the need to focus on a systems approach, look at the value and importance of leadership and governance and the favorable policy environment, measuring what matters and measuring it better, the value of shared learning and teamwork to drive implementation at every level, and co-designing your intervention based with the Ministry of Health and other partners based on the context. We see that countries are making exciting progress and achieving impressive results and milestones, but each country's context is different and unique, as is their journey. As partners, we need to consider what it means to support the countries and have a country-driven and owned quality improvement. This time is right to think beyond pilots and to think about sustaining system improvements at scale. Most importantly, we need to keep our work people-centered at the core of what we do. So this is an iterative journey of doing, learning, improving, and implementing. But ultimately, it's about doing the right thing, as we heard from Barbara at the beginning, at the right time and place for every person, every time. And as was stated before, achieving and sustaining gains in quality improvement is truly everyone's business. And we've seen from the discussion that this is really engaging and important. We are sorry we didn't have full time for a complete, taking everybody's questions. So we do hope that as MCSP and the partners that are involved, we continue the conversation. This is, as Lily said, it's a long journey full of potholes, but we need to make sure that we are on the right road with all the partners. Thank you.